Thank you so much, Dr. Vivek, for joining us on a podcast at Dawdle. Extremely grateful that you took out time on this Sunday afternoon to kind of share your insights with us. But before we get to the topics, Dr. Vivek, if you could run us through your experience so far so as to give a context to our audience.
Yeah, sure. Thank you, Rishikesh ji. Thank you for having me over. It's my pleasure to be on the podcast. So I'm a head and neck oncosurgeon by training. Journey in head and neck began in 2014 after completing general surgery post-graduation. I was wondering what to do next. And I came across head and neck oncology through the eminent Dr. Moni Kuria course. He's a very famous head and neck surgeon in the country. I got the opportunity to train with him for 2 years, got my fellowship in head and neck oncology, and I worked as a consultant in head and neck department at Narayana Health City, Bangalore, till from 2016 to 2025. And recently, at 2025 May, I joined Sparsh Hospital. They're starting their new branch in Hennur, which is going to be oncology focused, and I'm working there currently.
Yeah, and Spurs is a big name inside Bangalore.
Yes, Sparsh is, they are expanding. They have 6 hospitals in Bangalore.
So, sir, my first question is around your head and neck oncology.
Yeah.
What do you see as the most pressing challenges for patients and surgeons, today in this particular department?
Yeah. So there are 2 things in head and neck oncology from a early detection perspective. So screening and early detection is very important because when you detect a cancer early, the outcomes are better. So head and neck onco, basically I deal with oral cancer, is one of the most common cancers in the country. And that is one of the most common cancers I treat. Other than that, of course, thyroid cancers, throat cancers, salivary gland tumors, and things like that. So when I say head and neck cancer, I'm talking about tobacco related cancers such as mainly oral cancer, so buccal cancers, tongue cancers, as well as larynx cancers, voice box cancers. So it is important to detect these cancers early. And oral cancer is actually, it's quite easy to detect. All you need to do is, some expert needs to look into the mouth. There are early warning signs. There are pre-malignant lesions, like there are white patches, red patches. It's called leukoplakia and erythroplakia. So these will usually be there before the cancer begins. The challenge has been to get patients to come to the doctor early so that it can be detected early. When you detect it early, the outcomes are much better. It has been proven, actually, an Indian researcher called Dr. Shankar Narayanan, who recently passed away. He's a very famous epidemiologist, worked in Amsterdam. And he had actually done a screening of lakhs of patients. And he had actually proved that if you have a robust screening mechanism to screen patients who use tobacco, it actually saves a lot of lives. This actually, if this is implemented at a national level, we can actually detect a lot of cancers early and we can save a lot of lives. So that is from the screening perspective. So head and neck cancer, they affect some of the most basic functions of human life, like breathing, eating, speaking. And also when you have oral cancer and you do surgery for oral cancer, it can disfigure the face. Face is a person's identity. When you disfigure that, or when the face changes, it can change how they look at themselves.
Yes.
So one of the very important duties of a head and neck oncologist, I would say, is to focus on function and also the form. And this is actually, it can be quite challenging because there are certain limitations that we have with the technologies that exist today. We cannot restore tissue to what it was before the cancer set in. So this is another challenge that, that needs, as technology improves and as our understanding of these, of tissue and how to sort of modify tissue improves, these outcomes will get much better. But these are the 2 main challenges I would say that we are facing in head and neck oncology.
And, doctor, related to this itself, if you talk about cancer treatment, it's a multidisciplinary, coordination. It involves that.
Yes.
So
Yes.
how can digital health platform and electronic medical records improve communication across teams?
Yeah. So as you rightly pointed out, cancer in general, not just head and neck cancer, any cancer, it's a multidisciplinary effort. So there are different modalities to treat cancer. So I am a surgeon, but I cannot treat cancer in isolation. We need a good radiation oncologist. We need a good medical oncologist. And we also need other specialties. So these are the core onco specialties, but there are also other specialties which are vital to onco practice, such as radiology. We need a good pathologist. We need rehabilitation specialists. We need speech and swallow, especially in head and neck. We need speech and swallow therapists. We need physiotherapists. We need very good counselors. We tend to underestimate just how much of a mental impact
Yes.
this, a cancer diagnosis as well as cancer treatment has, not just on the patient, but on the family as well. So having a counselor who understands these things and who can connect with the patient and help them cope and help them get through the treatment and the repercussions of the treatment, this is very, very important. So when you have so many people involved in the treatment, definitely having a platform where real-time data and real-time opinions can be shared, it is absolutely important. And it definitely makes treatment much smoother and much easier for the patients as well.
Got it. And and also, so you have touched upon this, is that is the post-surgical rehabilitation
Yes,
is very critical in oncology.
yes,
So
yes.
what role do you see for all these telemedicine and digital rehab tools in
Yeah.
improving recovery?
Telemedicine is absolutely vital in follow-up. So the first visit cannot be telemedicine, I would say. Like when if you're talking about rehabilitation, say a patient needs to do speech exercises, voice exercises, and things like that. Or if they are meeting a counselor for the first time,
Hmm.
and they are trying to learn how to cope with the diagnosis, and the caregiver is trying to understand the repercussions and how the future is going to be. So that requires a physical presence and a physical meeting, and that bond needs to be established between the therapist and the patient and the family. But once that is done, follow-up is equally important. It's not enough to just teach them the technique and send them away. A lot of patients travel from outstation. They will not have therapists available locally. So having access to their therapist online makes a huge difference. It's a game changer, and it can improve compliance, and it can definitely improve outcomes significantly. So telemedicine is, in this day and age, telemedicine is absolutely essential part of any healthcare service, I would say.
Doctor, you also touched upon this thing which is called early detection inside
Yeah.
cancer. So have you seen some AI-based imaging and screening tools that are being used in India or outside?
Yes. In fact, when I was working in Narayana, we were actually working on a project. One of my colleagues, Dr. Samsam Sani, was a pioneer in this. He actually was, so oral cancer, that's the field that I work in. Oral cancer screening is not complicated. All you need to do is just look into the mouth. And like I said, there are pre-malignant conditions. There are early signs that a patient a person may be susceptible to cancer in the future.
Hmm.
So if we can pick this up early, then early intervention is possible, and we can potentially save lives. Now, the problem is accessibility to a specialist who is able to do this. There are two
Yes.
challenges actually. First one is accessibility.
Hmm.
Second is the denial that the patient has. So to answer specifically your this AI based tools, anybody can take a picture. Like now, smartphones are available everywhere. Anybody can take a picture. So Dr. Samsam was actually working on collecting these images, collating it, and training AI models so that it can detect pre-malignancies. Like malignancies, I think it looks very obvious. Most people will be able to tell that, if it is a cancer, even the patients themselves will know that there is some issue. But
Yeah.
detecting lesions which are pre-malignant, that I think AI can really help. And actually, Samsung has proved that these can be trained to a high degree of accuracy. Just train the patients, or if the patient is not able to do it, every village will have ASHA worker. They
Yes.
can be trained in clicking photos of high risk patients. There's no need to take photos of everybody's mouth. You need
Yes.
to target people who use tobacco because they are the ones who are most susceptible to oral cancer. So targeted screening, along with the AI integrated, image recognition and pattern recognition,
Hmm.
will be absolutely invaluable in detecting oral cancers.
Got it, sir. And once you say tobacco, it's only that gutka, or is it smoking as well?
Both. So in India, if you see, about 28%, according to the latest GATS data, about 28% of India's adult population uses tobacco in some form. And the more common form of tobacco usage is actually chewing tobacco. So gutka and,
Yes.
you know,
Pan parag and all that.
yeah,
Yes.
all of those things. But also smoking is also a significant part of that as well. So in the urban areas, the youngsters, they indulge more in smoking. If you go towards rural areas, it is more of gutka chewing.
Yes.
So both of these things contribute to oral cancer is more because of gutka. If you look at larynx cancer, lung cancer, and host of other cancers, it is smoking. But tobacco usage in any form is dangerous. It is a carcinogen. It has about 80 different chemicals which can cause cancer. You use tobacco in any form, you're putting yourself at risk, unfortunately.
And even eating all this pan and all also can lead to.
Yes. So people think that Araconut is, they sell it saying that it's a mouth freshener and it's, without tobacco, it is safe. Araconut is also a proven carcinogen. So even pan masala without tobacco is not safe.
Yes.
So in fact, a lot of states are now banning
Yes.
gutka. And that is a step in the right direction, but a lot more needs to be done because these industries and these lobbies are very powerful, unfortunately.
Yes. This is where my question was actually, these lobbies are so powerful that if they want some agenda to be floated, it's like floated.
Yes, absolutely. So I think the way to go about it is you need legislation to control their menace. But if you just legislate and you do not do anything on the demand side, it is important to reduce demand and supply simultaneously. If you reduce supply of something without reducing the demand first, then that can lead to bootlegging and black marketing and all of those things. So like the mafia in the US, it came up because of this.
Yes.
Because they suddenly banned, one fine day they just banned alcohol. But there is already demand for it in society. So with tobacco also, what we need to do is we need to target the college kids and the school kids because tobacco is a risk-taking behavior. And what we have seen is more than 90% of the people who use tobacco, they start this habit before the age of 20, 21.
Yes.
If you target them at that age, first thing is we have to deglamorize it because it is seen as a very cool thing to do, unfortunately.
Yes.
So deglamorize it, show it for what it is. It stains your teeth, it stinks your breath up. It, gives rise to a host of health issues, including, impotency and sterility and things like that. So it is not good for the body in any way. So if we are able to get that message across to youngsters, that is when we can reduce the demand for that product. And if we can reduce the demand, then we can start legislating. Only then the financial muscle also of the industry will go down. Because as long as people are buying their product, they will, have money to, indulge in propaganda. But the minute the demand reduces, then we can work on the supply aspect as well. So it needs to be a multi-pronged approach.
Absolutely, sir. Now we'll go to, this thing called surgical planning in neck and head cases, which can be extremely complex. So do you see all these technologies like 3D modeling, AR, VR, or simulation making a significant difference?
Yes, 100%. So there are two aspects to, like, especially head and neck oncosurgery. If we're dealing with oral cancers, I will focus on oral cancer because that's the most common cancer and that's the one we do surgery for. Like throat cancers and all, we only operate if other modalities fail. But in oral cancer, surgery is the primary modality of treatment. And as you rightly said, those are disfiguring surgeries. So there are two aspects to it. One is removing the cancer and second is the reconstruction. So for cancer removal, we go mainly by image guidance. We do a pre-operative CT scan or MRI or, whichever imaging that is required. And based on that, we plan our surgical margins. So cancer is such that we cannot leave any cell behind. At least, of course, there are exceptions, but most commonly, oncosurgeon's approach is we cannot leave any cell behind because even if you leave one cell, that can potentially cause a recurrence. So when we take out the tumor, we have to take it out with a margin of normal tissue around it because there can be some cells which are slightly away from the tumor. So imaging is immensely helpful in this. AR and VR will add value to. So the thing is, right now we don't have enough granularity, I would say, because I think what we need is, of course, this is aspirational. This is just me speculating about the possibilities. We need technology that will tell us exactly till where. So cancer is not just a phenotypic; it's a genetic disease, right? There like we have to find cells which have mutations and we have to remove all of that. So right now, we don't have the technology to demarcate exactly where the cancer is ending, which is why we have to take extra normal tissue. But if we can integrate, if we can find out, which are the mutations and able to tag it, and we're able to visualize it either by AR, VR, or whatever, in some form of imaging, and we are able to exactly delineate the cancer, then our surgeries will get much more accurate. So the functional outcomes also will be better because we can preserve the tissue which doesn't need to be removed. Right now, we are having to overcorrect because we don't know exactly where the cancer is ending. So that is with regard to cancer removal. Reconstruction wise, it is absolutely invaluable. We are already using 3D technology, especially for jaw reconstructions, where, the jawbone, when it has to be removed, the reconstruction is done using the fibula bone from the leg. So the fibula gives the advantage that it can be cut into multiple pieces, and if we get the angles right, it can restore the form and the function to near normal, and we can put dental implants, and we can give a near normal life back to the patient. And 3D technology makes this surgery faster and much more accurate. So we do like thin cuts on the scan, and we upload it onto a software, and we do a virtual surgery on the software. So we mark out exactly the extent of the cancer and how much needs to be removed. And then we upload the scan of the fibula as well. And we figure out where exactly to cut, like at what size and what length segments to cut. And this saves a lot of time when we're doing the surgery, makes the surgery much safer, and it also makes it much more accurate. Because with the free hand, whatever we do, it is not the same. 3D technology is invaluable. It is already being used. For soft tissue, I think it needs to evolve more because there are certain challenges, like technical challenges, like we cannot predict exactly how much it shrinks, soft tissue shrinks. Bone doesn't shrink, but soft tissue, when you take it from some other part of the body and place it there, it tends to shrink. So those challenges are there. So it's not very useful in soft tissue reconstruction, but jaw reconstruction, it is absolutely invaluable.
Got it, doctor. And I think related to this also, there was a question that reconstruction after cancer surgery impacts both function and appearance.
Yes.
And can digital modeling or bioprinting technology enhance the outcome?
Yes, it can. It definitely can. It already is enhancing outcome. But I would say, I think let's slightly go to the next level. So right now, what we are doing for reconstruction is we are taking tissue from some other part of the body, and we are using that to reconstruct. And then we are connecting its blood supply to the blood supply in the neck. So that's called free flap, free tissue transfer. Of course, molding it based on our 3D planning and all of those things definitely helps. But what I would like to talk about is tissue engineering. Okay, this is not exactly 3D technology, like it's not computer planning that you're talking about, but this is the next, I'd say, horizon in reconstructive surgery. What we need to create tissue, we need a scaffolding for the cells to grow. We need pluripotent cells, which means stem cells, which have the potential to differentiate into any kind of cell. And we need growth factors. So when you use these three things, we can grow tissue in the lab. Now, that is already being done. We are able to grow different kinds of tissue in the lab. People have even grown liver cells in the lab. Now, the challenge is to figure out how to transplant it into a human being and make sure that it survives. That is where the work is going on now. Mandible, tissue engineered mandible are already, people are doing good work in different parts of the world. Professor James Melville from Texas University, who has done this tissue engineered mandible reconstructions. There are people who are solving these problems as we speak. And this is going to be a game changer. Imagine if you can remove any tissue and grow it in the lab and put it back into the patient. That is what tissue engineering can offer potentially. Of course, there are a lot of challenges. We don't know how long it's going to take or whether even we'll be able to get there, but it is promising. If we are able to make bone in any shape, if you're able to make muscle in any shape, if you're able to recreate intestine and transplant it into the patient. So this is the next frontier in reconstructive surgery as far as technology is concerned.
And it's kind of, it leads to cloning as well, I think. Like
Yeah, technically, if you can grow organs in a lab, you can grow human being in the lab. That's just that is the reality of the situation. Of course, there are ethical questions and moral dilemmas, but the technology to do it doesn't yet exist. We will I am optimistic that we can get there someday.
And that's the best part about human beings. If they think, they will achieve it.
Yeah, very true.
Next, sir, is around robotic assisted surgery, which is expanding in oncology. And from your
Yes.
experience, will
Yeah.
it become a mainstream or will it remain a niche tool?
So robotic surgery in its current form has very specific indications. But you think about how a computer started. The first computer took the whole entire room, right? The whole room was one computer. So that's the stage at which robotic surgery is. We have these big arms, we need a separate console, there is no tactile feedback. So one of the big problems with robotic surgery right now is the surgeon is not able to feel the tissue. So we operate on the console and the robotic arms mimic a movement. So the advantage it offers is the movements are very precise. So that way it is very safe. But surgeons don't have tactile feedback. And for head and neck cancer, any cancer surgery, any oncosurgeon will tell you that we decide a lot of things based on feel. When the tumor feels different from normal tissue. And that makes a big difference for us. Having that tactile feedback, it's all a matter of time. It will happen. But the current robot that we use in surgery is mainly for pelvic surgeries. But as robots evolve, I think it will become commonplace. Not just commonplace, I think, because the advantages they offer are so good. Imagine if you're operating on, like, human eye has certain limitations, right? We can only see a narrow window of the electromagnetic spectrum.
Yes.
But imagine if you can integrate MRI images onto what you're seeing. So that's where VR comes into the play. Integrate VR to robotics. The robot will give the precision of movement, and the VR will allow you to integrate MRI images onto the patient as you operate. So you'll be able to tell exactly where blood vessels are, exactly where the nerves are, exactly where each structure is which you need to preserve. So it will make surgery very, very safe, it more accurate, and it will make it fast, because most of the time you go slow because you don't know what lies beneath.
Yes.
So if you can get that information, real time, then it will be a game changer. I think robotic surgery is here to stay. It can only get better as technology evolves. It is going to get safer, and the applications are going to be, I think, the whole spectrum.
That's a very great insights, like, basically robotic and especially the reconstruction part.
Yeah.
This can actually change the entire game across.
Absolutely. So, but we don't know how long it will take, whether it will happen in years, in decades, that remains to be seen. But I think technology is evolving quite fast. So I'm optimistic that in our lifetime, we'll be able to see a lot of changes in the way we do surgeries.
And sir, related to this itself, like, you have been a part of a lot of leading institutions.
Yeah.
Which are involved in collaboration and knowledge sharing across, a lot of research that's happening across the globe.
Yeah.
Would you like to talk a bit about it, like how this entire collaboration mechanism or platforms contribute to knowledge sharing and improve the outcomes of the research also?
Yeah. I think so. One of the important things about research is it needs to be reproducible, right? Otherwise, it's pointless. If I'm able to do something in some very specific conditions, then so now what is happening is collaboration is on the rise. We are seeing more and more multicentric trials and multicentric studies, and not just within the state or within the country, but across geographies. And we are able to, share data, share ideas, and collaborate in real time. And that definitely makes a big difference. And the thing is, say, for instance, if you want to study a rare kind of cancer, in my practice, I may not see those cases very often. So if you want to draw conclusions and get enough data to be able to decide what is ideal for those patients, then you need to collaborate with many, many centers, not just one or two, to get enough data. So in those ways, definitely access to data, access to expert opinions, say good statisticians, and also now with AI integration, analyzing data, and AI is able to even identify patterns and this thing that the human mind may not see. So definitely, uh, those things help.
But how closely is the doctor community working hand in hand with the researchers as well as with the technocrats? Because I think if we have to come out with something great,
Yeah,
that collaboration is important.
absolutely. So I think a lot more can be done in that regard. So the problem I think is a lot of doctors, they end up in a silo. Like they end up focusing on their practice and not really they don't think about what needs to be done, on a research front or a technology front and all of these things. Now, social media is changing that. There are platforms like LinkedIn where you see what other people are doing. You're exposed to a lot more ideas, and I think collaborations are on the rise. I would say definitely they're on the rise. Definite technocrats, clinicians, and researchers need to come together for optimal results. Because if researchers also they sit in their lab and they do their work, it's not of much practical use. They'll get a lot of papers out of it and all of that. What is important is translation. So translational research is what has the most impact. And for that, the clinicians need to get involved. And luckily, that is improving. Now things are the collaborations are on the rise.
And I've seen a lot of doctors also, getting into the technology domain and are building tools around that.
Yes, absolutely. So, yeah, I mean, traditionally it used to be you finish MBBS, you decide whether you want to do medicine, surgery, choose some branch, and then go into that. But nowadays, there are brighter kids coming out, I guess. They're looking at other possibilities. There are people who are getting into biotechnology. There are people who are getting into engineering after MBBS. So these people, they have domain knowledge in two different domains, and they can really make a big difference.
Sir, related to the cancer patients, and you basically kind of touched upon this thing, but we'll again come back to that point, is that cancer patients need long-term lifestyle support.
Yes.
So have you seen all these gamified health apps or these continuous monitoring tools really improve adherence and survivorship, outcomes?
Yeah. If I have, what do cancer patients need to do, like on their end, in order to ensure better survival or, better cancer-free survival and all of those things? They have to do the basics properly. Like they have to be on a good diet. They have to stay away from carcinogens. They have to reduce stress as much as possible in their lives and generally lead healthy lives, like exercise and all of those things. So these gamified apps do contribute in, maintaining a diet, reducing stress, all of these things. The other important thing is timely follow-ups. So definitely, apps and platforms like that do contribute. Finally, what matters though is the patient's own motivation. These are all tools. These cannot change the way a person behaves. So finally, the patient themselves have to be motivated enough to follow all these things, and then they can use these apps to improve adherence.
I got it. And also, if you look ahead like 5-10 years, what are the various use cases of technology where you see can mostly, kind of transform cancer care in the coming 5 or 10 years?
Yeah. So cancer care, I would say, so there's something called a digital twin where uh, you feed all the demographic data, the clinical data, the molecular data, the pathology data, whatever data you have about the patient, feed it on to the this thing to an AI platform, and you create a digital twin of a patient. So this can lead to highly personalized care. And also, this makes experimentation easier. So you can first do a virtual treatment and run it and see what the possible outcomes are. And I am optimistic that as the data gets more and more granular, like genetic testing is only now coming into the picture in a big way. It is not like not every patient, even cancer patients don't have genetic test. Like not all patients have genetic testing. But as the cost is brought down and affordability in the society improves, if we do a genetic testing for everyone, if you have that granular data, like genetic data, we already have the pathological and demographic data. And if we are able to run tests, see what works best for that particular patient, cancer care delivery can become highly personal. And I think that is important because right now we follow staging and we follow the guidelines where for this stage, you treat it like this, that sort of a thing. But while it is a beginning. We can't stop there because we have seen like even stage 1 cancer, it's not 100% cure rates, right? Like 80% of stage 1 patients get cured. Say of course, it's different for different cancers. Say in tongue cancer, stage 1 cure rates are around 80 to 90%. But there's still that 10% patients who don't seem to respond to that treatment. So we need to focus on improving that. I think our ambition should be to get 100% of patients cured. Why those 10%, they don't respond? I think that's where personalized care can make a big difference. And also, higher stage patients may be over treating a big percentage of the population. So we don't know. So as the data gets more granular, if we are able to run virtual treatments before we actually come to this thing, that can be a big game changer. And the other thing I already touched upon, tissue engineering. Like, yes, imagine if you can take out how much ever tissue you want and you're able to restore exactly to what it was before. Of course, we don't have technology for that now. The hope is we can get there at some point. And if we do, that can be another game changer.
Thank you so much, Doctor, for joining us on this podcast. And thank you. Extremely grateful that you took out time and shared insights.
My pleasure.
Very interesting things like tissue engineering is something, simulation is something.
Yeah.
Going to be
these are all aspirational technologies. It's something that we hope to see in the future. We don't have technology for it yet, just to clarify. Yeah.
And also you touched upon the genomic medicine, which is getting a lot of traction these days.
Yeah.
But I think, Doctor, getting the genomic medicines in will also involve a lot of supply chain challenges now.
Yeah. But so the thing is, when there is demand, supply will follow. Yes. Of course, there will be challenges, but those can be addressed. There's nothing insurmountable, I would say. First thing is the cost for the diagnostics and the testing needs to come down. And then the treatments also will become more affordable. Immunotherapy is another aspect that I would like to focus. For at least 2 decades now, we have been waiting for that magic pill that can cure all cancers. Unfortunately, that has not happened. And the reason for that is cancer is it's an umbrella term for many different kinds of illnesses. So there cannot be one cure for all cancers. That is very difficult, I think. But immunotherapy is where you use the body's own immunity to fight against the cancer. Yes. And, now new modalities like CAR-T cell therapy is coming. So CAR-T is where you take T cells from the patient. Yes. You teach it to recognize and fight against that particular cancer cell, and then you put it back and then it multiplies and it takes care of the cancer. So it has shown very promising results in leukemias and lymphomas, lymphatic related cancers. But hopefully, things like that can come into other cancers as well. Yeah, immunotherapy is another promising avenue for technological advance in cancer treatment.
And Doctor, at last, if you want to advise the policymaker or hospital administrators on some of the priority digital investments that they should make for oncology, what would that be?
So I think if you're looking at a policy level, the priority has to be early detection. So screening of common cancers, putting in technology where you try to make up for the lack of trained personnel in the rural areas. Indian healthcare has a strange dichotomy. There are a lot of doctors in the big cities and there's virtually no doctors in the rural areas. So there's cutthroat competition in the cities, and in the villages, they just don't have access to even the basic things. Yes. So we need to figure out how to level that playing field to make sure that the expertise that is available in the cities can be utilized for the rural population as well. So I think technology can bridge that. And I think that should be the focus of policymakers, at least at a country and a state level.
Thank you so much, Doctor, for joining us. Extremely insightful session.
Thank you.
And that this is going to be hugely beneficial for all the healthcare leaders who will be watching this show.
Thank you. Thank you. Very kind of you to invite me. Thank you. I appreciate it. Thank you.